Backed by popular demand, today we're conducting our second interview with a old school and a new school neurologist. Today's topic is treating MS. Don't turn away, because that interview starts right now. Today, I am excited to welcome back to the set two MS neurologists, one who is admittedly old school and one who considers himself new school. Now, this past summer, during their first interview on this channel, they were met with rave reviews, and I am delighted that they both accepted an invitation to return back to the set for a second interview. In preparation for today, our viewers have written in questions for both of the neurologists. Without any further ado, please help me to invite to the set the old school neurologist.
Well, hello there, young man. It's a pleasure to be back here and to educate someone like you.
Well, thank you and welcome back, old school. And now, please help me invite to the set our new school neurologist. Howdy, and thanks for having me back. I specifically want to say thank you to all the viewers on your channel that were nice enough to write in their questions. Thank you. Gentlemen, our viewers are as excited as I am to have you back on the show. They have submitted questions for both of you to answer, and we look forward to learning from both of you. So let's jump in. Question 1 comes from PP Kathy Stein, who asks, when is the right time to start a patient on an MS medicine? Old school neurologist, would you please start us off?
Slow and steady wins the race, and we don't want to be too hasty. We might want to watch and see how you do for the first year, because we might not need to start these drugs right away. If you're having very frequent attack and you're having new spots on your MRI, maybe we'll sit down and talk about putting you on something. But if you're not having any more disease activity, maybe we don't need to give you all that stuff.
New school neurologist, would you care to comment? Whoa. Okay, so I strongly disagree. There is a therapeutic lag between the onset of brain damage and how it plays out and manifests with neurological disability, which can take 15 years. I'm not treating you for you today. You today, you feel fine. I'm treating you for 25 years from now. The decisions we make today will set the trajectory for what happens literally for decades to come. And brain damage, spinal cord damage, even asymptomatic, meaning you don't even know about it, that damage will set a faster trajectory with worsening disease outcome when you're 20, 30 years down the line. We have a window of opportunity when we can really impact inflammation, and that window is early on. It's during the first 5, 10 years of the disease. So in my strong opinion, we need to start therapy the moment we clarify this is clinically isolated syndrome. We literally do not have time to waste. Question number 2 comes from Callie, who writes, if it's new or mild and no additional lesions or progression have been noted in a long time, should the patient begin disease-modifying drugs? In other words, what are our thoughts on treating very mild MS? And should we treat everyone?
Simply put, no. We don't need to just run out and put everyone on medicines. We might not need to treat you if your disease is acting mild. Now, let's not forget, drugs have side effects. And if we don't have to use a drug, then in some ways, maybe that's better for you.
I think we need to unpack this a little bit more. For starters, we need to define the term mild. Mild doesn't mean you're okay. Mild doesn't mean you have a normal quality of life, that you are unfettered in your options for activities of recreation and vocation and daily living. Mild can become aggressive, and we can't go backwards, meaning if the disease picks up, we can't rewind time. We have to be planful ahead of time. Guys, we have to place the benefit risk of a given drug in the context of the risk of undertreated MS. I am much more scared of undertreated MS than I am of the side effects of the medicines. And I want us to consider starting a disease-modifying therapy, even in a mild case, as an insurance policy. It's an insurance policy against future disease activity. Moreover, I firmly believe that we can mitigate the risk of side effects of medicines by being really good at our job. By being good shepherds of the brain, by being good doctors, we can help navigate through side effects. We can't give back brain damage from undertreated MS. Gentlemen, thank you for your responses. Question number 3 comes to us from Melanie Parker, who writes, why are these old schoolers starting people out on injections? Do they really believe that this is the best way to go? Do they feel at all responsible for their patients getting worse while on injections? Wow, that's quite a question. Old school neurologist, would you care to answer?
Now you look here, young lady. I'm the doctor, and I want to do what's best for you. Now, we're going to start you off on something easy and breezy, something that doesn't have a lot of side effects, but, it's kind of mild in its efficacy, and I'm going to tell you whether it's working or not. Now, if it works out, then we're okay, and you don't need to worry, and I don't want you to worry. I'm going to make that decision for you. And if things don't work out, well, then maybe we'll escalate to some of these stronger drugs, but you're not going to like being on them. All right? Now, I'm going to make sure that we do this okay. I want you just to listen.
Okay, for starters, the escalation model is flawed. We can't capture all disease activity. Patients aren't fully aware of it, doctors don't pick up on it, and much of it early on in the disease is silent. And the person can accrue brain damage and spinal cord damage, which they're not fully aware of, or that we miss on a screening examination. I don't use injections in my practice because we have better medicines. And injections aren't necessarily cheaper. Injections aren't necessarily safer. In the modern era, when we have 21 different formulations of medicines, I really struggle to understand why someone would want to use something that was cutting edge in the 90s when we have drugs today that can do more. They can do more at slowing brain volume loss. They can do more at slowing disability progression. They can do more about shutting down the MRI and stopping relapses. Come on, it is high time that we move forward with our options for treating people with MS. Viewer LW asks a question along the same lines. Why doesn't the old school neurologist practice early and aggressive MS treatment? Care to comment?
Now, if it ain't broke, don't fix it. If it ain't broke, we don't need to fix it, okay? Now, medicines have side effects. And these newer medications, well, they are complicated medicines, I'll tell you. They are annoying to use. I mean, they are involved and they require a lot of effort on my part. I mean, I got to check all these things and think about all these different things. And the older medicines are easier and they're safer. Gosh darn it, they've been around a long time. And so if injections work, I don't need to put you on all that other stuff where I've got to do all this monitoring and where I've got to worry about all these weird things. And if it ain't broke, let's not fix it, okay?
New school, care to comment? Look, if I could predict ahead of time that you are guaranteed to have quiet disease for 40 or 50 years, then yes, we could start with a mildly effective medicine. But we don't know that. And if, God forbid, you end up having aggressive disease, we can't give you back what you've lost. As such, I want to bring a SWAT team to a knife fight as long as you're on board. It's my goal to treat someone with the most effective medicine that they're comfortable taking. And they actually have to be comfortable taking it, which means we need to have a real benefit-risk conversation. I am known to sometimes ask 3 rather inflammatory questions, and I'm going to ask them now. I let you know ahead of time that they're inflammatory, but they're all intended to help you think into the future because it's your future self that we're trying to treat. Inflammatory question number 1. God forbid if this was breast cancer as opposed to MS. Would you let me use the 4th best drug available? Question number 2. Presuming that your daughter is young, is it okay to wheel her down the aisle on her wedding night, or is it your preference to walk her down the aisle? Question number 3, I asked the spouse. I showed you your spouse's MRI. I showed you the brain damage on the scan. So I asked the spouse, how much more brain damage do you feel comfortable letting this person accrue as I take care of them over the next 10 years? 20%, 30%, what have you. Now, obviously, these are inflammatory questions, and it was not my intention to upset you. It is my intention to help you think farther down the line at the goals of what we're really trying to accomplish. Gentlemen, viewer Crystal McCrae asks you both, I'd like to know how the thoughts and opinions differ about the meds used to treat MS today.
All right, young person, let me break it down for you, okay? Here we go. Now, the injections, and these are medicines that have been around a long time, like Copaxone and the interferons. Now, these are tried and true, and they can slow the disease down a little bit, and we know what we're getting ourselves into. Now we have all these fancy pills, and they're moderately efficacious, but they can be dangerous. I tell you, they're not like the injections. And lastly, we have these newfangled infusion medicines. Whew, they are too expensive and they are too dangerous. And I just don't want to mess around with very many of them at all. No sirree, Bob.
So this is actually a really big topic. At the end of 2019, as we record this interview, there are 21 different formulations of FDA-approved medicines to treat MS. My approach is as follows. It starts with taking a very careful and thorough medical history, doing a comprehensive neuro exam, looking carefully with the family at the MRI scans, any spinal fluid, and any blood serum labs that we have. Then we have to think about the diagnosis, how we confirm it. We have to think about the prognosis. What are the prognostic factors that might predispose this individual to have more aggressive disease? We then turn our attention to discussing life goals. I'm not talking about goals of MS, I'm talking about goals of life, like climb Monte Picchu or finish your master's degree. And only after have we done all that do I feel that we're ready to start to talk about MS disease-modifying therapies. It's my practice to write up on the whiteboard the 4 drugs that I think you are eligible for in order of efficacy. Now, that doesn't mean that we're going to pick the most efficacious one. It just means that I'm going to start talking about the most efficacious one. And I will share with you the good, the bad, and the ugly of that drug. And if you agree, that's what we're going to do. If you don't agree, we're going to downgrade the option to the second best option, in my opinion, and we're going to talk about that. And in doing so, we're going to try to custom fit the most effective drug that you're comfortable taking for you at that time. When we're looking at drugs today, we're looking well beyond relapse rate reduction and decreasing spots on the MRI. We've moved way past that. We now can demand from our drugs that they can slow brain volume loss, that they can help us achieve NEDA, no evidence of disease activity. It's even reasonable that we ask for confirmed disability improvement. Not all the drugs can do this, and it's my goal to spend time with drugs that can. Just my 2 cents. My colleagues, Admir asks the following question. How do you decide when to change disease-modifying therapies? If a relapse occurs or if an MRI shows new lesions? We'd like to hear from both of you. Old school neurologist, what are your thoughts?
Change, change, change. That's all you kids want to do is change things up. I mean, we are not changing drugs like we change underpants, I'll tell you that. Now, if you have a new spot on your MRI, just one little tiny new spot, I mean, come on. We might be able to go another many, many years. We don't need to make a change. And if you have an attack, I mean, did you recover from the attack? I mean, do we really need to make a change? I mean, let's be reasonable here. What? That spot is brain damage. That spot is an attack on the holiest of holies, the supercomputer that runs the body, the only untransplantable organ system. That's not okay. In my opinion, if you're on a disease-modifying therapy, we need to discuss change if one of 5 things happen. If you have one of 5 things occur while you're taking a DMT, we need to talk about whether or not it's time to escalate. Those things are, number 1, an attack while taking the drug. Number 2, is a new spot on the MRI, because to me, a new spot on the MRI is the same thing as an attack. Number 3 is new changes on your exam. So if I examine you and I see that things are getting worse, that's cause to discuss, do we need to do something different? Number 4 is if you're failing the litmus test of life. If you are backing away from life's activities because MS is impeding your ability, I'm not okay with that. And if you're taking a disease-modifying therapy, we need to ask ourselves the question, is this the right one?
The fifth time that I would consider switching or escalating is if you no longer can tolerate the medicine you're taking because the side effects and the tolerability have gotten worse for you, or if you're no longer comfortable with the safety profile. If you have any of those 5 things while taking an MS DMT, I think we need to discuss whether or not we change. I'm not saying we're gonna change, I'm saying that we need to discuss it. Viewer AO 3030 presents the following case study. Should a patient with no clinical disease activity and no relapses after 5 years since diagnosis switch disease-modifying therapies after one tiny new lesion that appears on the cervical spine MRI after 5 years of diagnosis? I'd be very curious, as would our viewers, on how both of you neurologists would address a case just like this. Old school?
Now, this is one of these situations where we don't need to make a change. We can just repeat that MRI in a year or two, and we can see how things go. And this is not a big deal. We're just going to watch and make sure you're okay.
New school neurologist, your thoughts? Respectfully, I have a different opinion. For starters, a cord lesion is nothing to sneeze at. That's very, very serious. The cord is eloquent, and damage to the spinal cord very rarely goes unnoticed. And so when I see that my patient is accruing spinal cord damage, to me, that's a really big deal. I think that we first need to explore adherence. Are you having any difficulties tolerating taking the medicine? If you're taking your pills 5 days a week instead of 7, or if you're missing shots because it hurts or because your lifestyle is such that sometimes you forget or don't get to it, we need to explore that together. Because if you're not taking the medication as prescribed, that's something that we need to consider. If you are taking the medicine as prescribed and we've suffered a spinal cord lesion, that is nothing to ignore. And in my strong opinion, we either A, need to escalate to a better drug, or B, at least agree upon the threshold of when we would escalate. So if that's not enough to make you escalate, are you going to be okay escalating if one more thing's happened? Or are we going to image you more frequently to make sure that we don't miss something? This is not something to ignore. Viewer Newly Natural presents another case to consider. I'm in between meds, Tysabri injections, last med, and probably need to move on to another med. Which one? Already had ABC drugs, had MS for 20 plus years. Gentlemen, what are your thoughts?
20 years? Well, maybe you don't need to be on a medicine any longer. I mean, gosh darn it, that's a long time you've gone. You know what I mean? Now, if we do need to think about a medicine, and I'm not even sure we do, we might want to go back to the drugs that we know and love, the drugs that are safe, those injections that I grew up on. We could always go back and revisit those and get you off those crazy infusions. I mean, come on.
Tysabri is a highly effective medicine. And I think that we need to first consider, why are we considering a switch? Why are we considering coming off? If you suffered breakthrough disease, a new spot on the MRI, or a new attack despite Tysabri, then I think that we are obligated to stay on highly effective therapies. We might need to switch to another highly effective drug, such as another monoclonal, say ocrelizumab or alemtuzumab. If you're considering switching because of difficulties with tolerability, you're stable in your disease, but you're not able to tolerate receiving the Tysabri, or because the Tysabri risk profile has changed, then that's a different set of variables, and we might be able to consider something else. If we are dealing with the second half of the disease, and the disease has been quiet, and we're no longer comfortable with side effects, that might be a situation where we discuss de-escalation. Not stopping medicine, but de-escalating to something that is better tolerated or more easy to take, which might not be as efficacious as the drug that you are on in groups of people, but still might hold your disease at bay. There's a lot that we need to consider. We also need to revisit why we came off drugs in the past. All of these things factor into a decision. Amanda Anderson asks, yeah, I'd like to hear from a new school neurologist on their thoughts on new treatments for MS. And our viewers would like to hear from both of you gentlemen. Old school, please provide us with your thoughts.
New can be dangerous. That's right. And I think if we just wait 10 years, we can let other people figure out those risks and we don't have to bother with them ourselves. I mean, we're not in a hurry here, guys. Come on.
The future is bright. Our ability to quell inflammation in this disease has never been better. And as new disease-modifying therapies hit the market, our options, our different mechanisms of action for how we try to quell inflammation in the brain and spinal cord grow. And what we can demand from these drugs keeps getting better and better. We're no longer satisfied today with decreasing relapses and stopping new spots. We now demand no evidence of disease activity, and we can ask for confirmed disability improvement. We can demand that we have slowed rates of brain volume loss, and we can demand that people stay in the workforce longer. I really think as we go into the future, we're going to need 3 types of therapies. Anti-inflammatory drugs, like the current disease-modifying therapies. We also need a remyelinating agent, and there's a tremendous amount of active research studying remyelination. It's my opinion that we will probably have a remyelinating agent on the market in under 10 years. That's not that far from now. Lastly, we need a third agent, a neuroprotective agent, and that doesn't exist yet. But there's a lot of research going on, and I think it's just a matter of time. The future truly is bright. Rosalind A. asks, I would like to know what everyone thinks about HSCT, or hematopoietic stem cell transplantation. Old school neurologist, would you like to start?
Stem cell transplants? I mean, come on, I'm not an oncologist. I'm not treating cancer here. That's crazy talk. I'm a neurologist, all right? So let's get with the program.
New school, what are your thoughts on hematopoietic stem cell transplants? I'm not sure I share that opinion. Now, I do agree that stem cell transplantation is not prime time. It's not ready in the United States that you just go out and sign up for it. But I think we're getting closer. In my opinion, today, we should not do stem cell transplants outside the context of a controlled clinical trial, at least not in the United States. I do need to point out that the safety of this procedure is getting better and better. And I think that within my lifetime, stem cell transplantation will become prime time, but it's not there just yet. This has certainly been an informative interview. Last question. Gentlemen, do either of you have any closing remarks?
Well, sure, Sonny. I have a couple thoughts and comments. I mean, I'm a neurologist, and I'm going to do my job putting you on a medicine I'm comfortable with. And then when you come in, I'm going to take a look at you, and I might get an MRI, and that's my job, all right? This is your disease, okay? All right?
Well, I'd certainly like to say thank you for the opportunity to share my views on treating MS. I'd like to say thank you to the viewers that were kind enough to write in those awesome questions. It's my goal to help you be the most awesome version of you despite having this disease. And it's my belief that it takes a team. It really takes a village. And I want to be a key village member. I think I speak for all the viewers on this channel when I say thank you to both the old school and the new school neurologist for sharing their views on treating multiple sclerosis. My name's Aaron Boster, and thank you for learning about MS with me. If you're impacted by MS and would like to hear more from the old school and new school neurologists, check out their first interview. I'll post it right there for you. If you haven't yet subscribed to the channel, please consider doing so. Just click that circle with my face on it. Go ahead, click my face. And until my next video or my next live stream or my next interview with old and new school neurologists, or the next time I see you in clinic, this is Aaron Boster saying take care.